HY Review, Biostatistics and Ethics. 40 exam-style questions on the material students lose the easiest points on. Read the command first, scan the clues, commit, and move. 40 questions, 60 minutes. Clock starts now. What is the expected effect of lowering the cutoff? Investigators evaluate a new serum assay for early pancreatic adenocarcinoma. At the current threshold, the test misses several patients who truly have the disease, so the team lowers the positivity cutoff to capture more cases. Read the command. The effect of lowering the cutoff. A lower threshold calls more results positive. You catch more true cases, but also more false alarms. Lowering the positivity. Cutoff makes it easier to call a result positive, so more people who truly have disease are flagged. Sensitivity rises. But the same loosening also flags more people without disease, generating more falsely positives, so specificity falls. Sensitivity and specificity trade off against each other as you slide the threshold. You cannot raise both by moving a single cutoff. The correct answer is C. The reciprocal option describes raising the cutoff, which makes the test stricter, higher specificity but lower sensitivity. The opposite manipulation choice, A wrong. Claiming both properties rise is impossible from a single threshold shift, because the sensitivity-specificity trade-off is fixed by the overlap of the diseased and non-diseased distributions, choice B wrong. Lowering the cutoff therefore raises sensitivity at the cost of specificity. How do the predictive values change in the low prevalence setting? A screening test with a fixed sensitivity of 95% and specificity of 90% is first used in a specialty clinic where disease is common, then applied unchanged to a low prevalence general population. Read the command, predictive values in a lower prevalence population. Fewer true cases among positives, lowers PPV, more true negatives raises NPV. Predictive values depend on prevalence. When prevalence falls, a positive result is more likely to be a false positive, so positive predictive value drops. Meanwhile, most people are truly disease-free, so a negative result is even more trustworthy and negative predictive value rises. Sensitivity and specificity, in contrast, are intrinsic to the test and do not move with prevalence. The correct answer is A. The opposite pairing, higher PPV with lower NPV, is what happens when prevalence rises, not false choice B wrong. Calling predictive values intrinsic to the test confuses them with sensitivity and specificity, which are the prevalence-independent properties. PPV and NPV always shift with prevalence choice E wrong. So lower prevalence gives a lower PPV and a higher NPV. Which property is independent of prevalence and converts pre-test odds to post-test odds? A physician wants one test property he can carry from a high-prevalence referral hospital to a low-prevalence community clinic and apply directly to each patient's pre-test odds without recalculating for the new population. Read the command, a prevalence-independent property that updates odds, that is the likelihood ratio. The likelihood ratio is built only from SC sensitivity and specificity, LR positive equals SN divided by 1 CSP score, so it is I independent of prevalence. It plugs straight into Bayes as post-test ODDS equals pre-test ODDS times the LR, letting the same number be applied in any population regardless of how common the disease is. The correct answer is E. Positive and negative predictive value both move with prevalence, so neither can be carried unchanged between a hospital and a community clinic. Choices A and B wrong. Number. Needed to treat an absolute risk reduction are measures of treatment effect, not diagnostic properties that update pre-test odds. The likelihood ratio is the prevalence independent link between pre-test and post-test odds. What does assay X's larger area under the ROC curve indicate? Two diagnostic assays for the same infection are compared by plotting sensitivity against 1 mile specificity across every possible cutoff. Assay X has an area under the curve of 0.92. Assay Y has an area of 0.71. Read the command. The meaning of the larger AUC, it reflects better separation of diseased from non-diseased across all thresholds. The area under the ROC curve summarizes a test's discrimination, its ability to rank a diseased patient above a non-diseased one. Across all cutoffs. An AUC of 0.5 is no better than a coin flip and 1.0 is perfect, so X is 0.92 versus Y is 0.71 means assay X SE pairs disease from non-disease better overall. The correct answer is B. An AUC of 0.92 is high but not 1.0, so the test still misclassifies some patients. It is not perfect choice. E wrong. A larger overall area does not guarantee a lower false negative rate at every cutoff because two ROC curves can cross. One test can win overall yet lose at specific thresholds. Choice C wrong. AUC measures discrimination and is independent of prevalence and PPV, so the larger area simply means better overall discrimination. Which statement best describes his post-test probability? A 60-year-old man has a pre-test probability of coronary disease of about 20%. He undergoes exercise stress testing, which has a positive likelihood ratio of 4, and the result is positive. Read the command. The post-test probability after a positive test with LR4. A positive test with an LR above 1 pushes probability upward. A positive likelihood ratio greater than 1 always moves the post-test probability above the pre-test value. The formal update acts on ODDS, not raw probability. Pre-test odds for 20% are 1 to 4 DDO 25 multiplied by an LR of 4 gives post-test odds of 1.0, a post-test probability of about 50%, clearly higher than the starting 20%. The correct answer is D. The tempting shortcut of multiplying the probability by the LR, 20% of 4, 80% is wrong because the likelihood ratio multiplies ODDS, not probability. The true post-test value is about 50%. Choice C wrong. A positive result is informative, so the probability does not stay unchanged. Choice B wrong. With an LR above 1, the post-test probability must rise above the pre-test 20%. What happens to the disease's prevalence and incidence? A chronic disease that was once rapidly fatal now has a new treatment that lets patients live for decades, though it does not cure them. Over the following 10 years, the number of new cases arising each year stays exactly the same. Read the command. Effect on prevalence and incidence. Longer survival with the same number of new cases piles up more living patients. Prevalence is approximately incidence times duration. A treatment that extends survival without curing lengthens disease duration, so patients accumulate and prevalence rises. Incidence counts only new cases per year, which the STEM holds constant, so incidence does not change. Anything that makes people live longer with a disease inflates prevalence while leaving incidence alone. The correct answer is A. Incidence measures the rate of new cases, which the STEM says is unchanged, so it cannot be rising. Choice B wrong. Treatment here prolongs life rather than curing, so it does not remove patients from the prevalent pool. Prevalence goes up, not down. Choice E wrong. Same incidence plus longer duration means higher prevalence with unchanged incidence. How are the reliability and validity of their grading best described? Two radiologists independently grade the same 100 mammograms and agree with each other on nearly every film. However, when the same breasts are later biopsied, their grades frequently fail to match the true presence of cancer. Read the command, reliability versus validity. They agree with each other, but disagree with the biopsy truth. Reliability is reproducibility, consistency of a measurement. Here the high INT, a rater agreement between the two radiologists, a high kappa. Validity is accuracy, how close the measurement is to the truth. Here the biopsy. Because the readers consistently agree with each other but consistently miss the ACTO cancers. The grading is reliable, precise, but not valid and accurate. The classic tight but off-center dartboard. The correct answer is C. Valid but not reliable is the reverse pattern. Scattered readings that average onto the truth, which is not what happens here, since the readers are highly consistent. Choice A wrong. Calling the grading valid ignores that it repeatedly misses true cancers on biopsy. The gold standard. Choice B wrong. Consistent agreement with the inaccurate result is reliability without validity. Which measure of association fits this design, and what is its approximate value? A case-control study enrolls 100 patients with bladder cancer and 100 cancer-free controls and asks each about prior smoking. Among the cases, 75 smoked. Among the controls, 50 smoked. Read the command, the right measure, and its value. Case control starts from disease status, so the measure is the odds ratio. The case control study samples on disease status, not exposure, so incidence and true risk cannot be computed. The correct measure is the ODDS ratio. The odds of prior smoking among cases are 75, ACE-3, ACE-3. Among controls, 50-51. The odds ratio is therefore 3:1:3, meaning bladder cancer cases had about THRE teams, the odds of prior smoking. The correct answer is E. Relative risk requires eye incidence in exposed versus unexposed cohorts, which a case control design cannot provide because subjects are selected by disease status. So no relative risk value is valid here. Choice B, wrong. An odds ratio of 6 comes from mispairing the cross product. The correct calculation, 75-50, 25-50 equals 3. Choice D, wrong. Case control data yield an odds ratio of about 3. What is the relative risk of lung cancer in smokers? A prospective cohort follows smokers and non-smokers and records the incidence of lung cancer over 10 years, 30 per 1,000 among smokers and 6 per 1,000 among non-smokers. Read the command, relative risk in smokers. A cohort gives incidences, so divide the exposed risk by the unexposed risk. A cohort study measures eye incidence directly, so you can compute true relative risk, the risk in the E exposed divided by the risk in the unexposed. Here, that is 30 per 1,000 divided by 6 per 1,000, which equals 5 times the risk of lung cancer compared with non-smokers. The correct answer is B. The value 24 per 1,000 is the attributable risk. The difference 35.6, which measures excess risk, not the ratio. The question asks for choice C wrong. A result of top I2 is the ratio inverted 2 is the ratio inverted 630, which would describe a protective effect and is the wrong direction choice. Dividing the two incidences gives a relative risk of 5. What is the number needed to treat to prevent one event? In a randomized trial of a new drug, the primary event occurs in 8% of the placebo group and 3% of the treatment group over 1 year. Read the command, number needed to treat, find the absolute risk reduction first, then take its reciprocal. Number needed to treat is the reciprocal of the absolute risk reduction. The AR is the difference in event rates. 8% minus 3% equals 5% or 0.05. NNT equals 1 divided by 0.05, which is 20. You must treat about 20 patients to prevent one event. The correct answer is D. The value 5 is the ARR expressed as a percentage, not its reciprocal. NNT is 1T ARR, not the ARR itself. Choice A wrong. A result of 40 would come from having the true ARR to 2.5%, AW25%, U2.duty25, but the actual absolute reduction is a full 5%. Choice E wrong. 1 over 0.5 gives an NNT of 20. What does this hazard ratio indicate? A Kaplan-Meier analysis compares a new chemotherapy with the standard regimen for advanced cancer. The hazard ratio for death with the new drug is 0.7, 95% confidence interval, 0.55, 0.88. Read the command, interpret the hazard ratio of 0.7. It compares the instantaneous rate of the event between groups over follow-up. A hazard ratio compares the instantaneous event rate, the hazard, between two groups at each moment of follow-up. An HR of 0.7 means the new drug carries a hazard of death that is 30% lower than standard therapy at any given time. Because the 95% confidence interval 0.55-0.88 does not cross 1, the effect is also statistically significant. The correct answer is E. A hazard ratio is not a ratio of survival times, so 0.7 does not translate into patients living exactly 30% longer on average. That conflates hazard with median survival choice, a wrong. The result I is statistically significant because the confidence interval excludes one choice C wrong. An HR of 0.7 means a 30% lower instantaneous rate of death, not a 70% reduction. What is the attributable risk among the exposed? The excess risk due to smoking. The incidence of bladder cancer is 50 per 100,000 among smokers and 10 per 100,000 among non-smokers. Read the command, attributable risk in the exposed. That is the difference between the exposed and unexposed risks. ATT attributable risk in the exposed is the EXE-SS risk that exposure adds. The risk in the E-exposed minus the risk in the unexposed. Here that is 50 per 100,000 minus 10 per 100,000, which equals 40 per 100,000. The extra bladder cancer cases per 100,000 smokers that can be attributed to smoking itself. The correct answer is B. The value 80% is the attributable risk, percent, 50%, 50%, 50, which expresses the proportion of the exposed risk due to smoking, not the absolute excess. The question asks for choice. D wrong. A result of 5 per 100,000 is the relative risk 50B10-10-5, a ratio rather than a difference, and it isn't even in per 100,000 units. Choice A wrong. Subtracting the two incidences gives an attributable risk of 40 per 100,000. Which study design is most appropriate? Investigators want to study risk factors for hepatic angiosarcoma, a very rare malignancy, and need an efficient design that can look back at multiple prior exposures without following a huge population for decades. Read the command, best design for a rare disease. Start from the cases and look backward at exposures. For a rare disease, the case control design is most efficient. You start by assembling people who already have the disease, match them to controls, and look backward at prior exposures. This avoids following an enormous cohort for years just to accumulate a handful of cases, and it lets you examine several candidate exposures at once. The correct answer is A. A prospective cohort is inefficient for a rare disease. You would need to follow a massive population for a very long time to observe enough cases. Choice B wrong. A randomized controlled trial cannot be used because you cannot ethically assign people to a presumed harmful exposure, and it too is impractical for a rare outcome. Choice D wrong. The efficient answer for a rare disease is a case control study. Which analytic approach should be used? In a randomized trial comparing surgery with medical therapy, several patients assigned to surgery refused it and instead received medical therapy. The statistician wants an analysis that preserves the benefits of randomization and avoids bias. Read the command, the analysis that preserves randomization. Keep patients in their assigned groups, regardless of what they actually received. Intention to treat analyzes every patient in the group to which they were randomized, regardless of whether they adhered or crossed over. This preserves the balance of confounders created by randomization and gives a conservative, real-world estimate. Analyzing patients by the treatment they actually received would let non-random self-selection back in and BIS the result. The correct answer is D. Per protocol, analysis includes only patients who completed their assigned treatment, which discards the non-adherent group and breaks the randomization, inflating the apparent benefit. Choice A wrong. As treated analysis groups patients by the therapy they actually got. Reintroducing the very self-selection randomization was designed to remove choice B wrong. Intention to treat is the approach that protects randomization. What error has been made? A study finds that countries with higher average dietary fat intake have higher national breast cancer rates. The authors conclude that an individual woman who eats more fat will therefore develop breast cancer. Read the command, the error in the conclusion. They inferred something about individuals from group-level averages. This is the ecological fallacy, drawing a conclusion about individuals from data measured only at the GRP aggregate level. National averages of fat intake and cancer rates cannot tell you what happens within any single woman because the exposure and the outcome were never linked in the same person. They were merely correlated across populations. The correct answer is C. Confounding is a distortion by a third variable within a study of individuals. The flaw here is specifically the leap from group data to an individual claim, not an unmeasured confounder. Choice A wrong. Recall bias involves differential memory of exposures in a case. Control study, which is unrelated to this population level comparison. Choice D wrong. Inferring individual risk from aggregate data is the ecological fallacy. Which bias best explains the spurious hospital association? A hospital-based case control study reports a strong association between a chronic skin disease and a chronic bone disease. When the same question is studied in the general community, the association vanishes. Both diseases independently increase the likelihood of being hospitalized. Read the command, the bias behind a hospital-only association. Selecting hospitalized subjects distorts the link. This is Bergson bias, a form of selection bias. When both the disease and the exposure independently raise the chance of hospitalization, studying only hospitalized patients oversamples people who have one or both conditions, manufacturing an association that does not exist in the general population. The bias arises from HLW subjects were selected, not from how they answered questions. The correct answer is B. Recall bias comes from cases remembering exposures differently than controls, a problem of information rather than selection. Nothing here suggests differential memory. Choice A wrong. Confounding is distortion by a real third variable that is associated with both exposure and outcome. Here, the association is entirely an artifact of selecting hospitalized subjects, which disappears in the community. Choice D wrong. Selective omission of hospitalized patients is Bergson bias. Which bias is operating? In a case-controlled study of birth defects, mothers of affected infants search their memories and report far more prenatal exposures, medications, infections, chemicals, than mothers of healthy infants, who recall their pregnancies only vaguely. Read the command, the bias from differential memory. Affected mothers remember exposures more thoroughly. This is recall bias, a type of ion formation bias classic to case control studies. Because the outcome, one birth defect, is already known, mothers of affected infants scrutinize their pregnancies and remember exposures that control mothers overlook. The differential accuracy of memory between cases and controls falsely strengthens the apparent exposure disease link. The correct answer is E. Selection bias concerns how subjects entered the study, not how accurately they remember. The problem here is memory, not enrollment. Choice B wrong. Lead time bias is a screening artifact about earlier diagnosis, entirely unrelated to a case-control study of birth defects. Choice A wrong. Differential memory between cases and controls is recall bias. Which bias makes the screening look beneficial? A new screening test detects a cancer 3 years earlier than it would have been found clinically. Screened patients appear to survive longer from the time of diagnosis, yet careful review shows their actual date of death is no different from unscreened patients. Read the command. Why earlier detection fakes a survival benefit? The clock starts sooner, but death comes at the same time. This is lead A time bias. Screening moves the moment of diagnosis earlier without changing the actual moment of death. Measuring survival from the now earlier. Diagnosis date makes screened patients appear to live longer, but the extra survival is only the lead time added at the front end. The disease course and date of death are unchanged. The correct answer is A. Length time bias is a different screening artifact. It comes from preferentially detecting slow W growing tumors, not from starting the clock earlier on the same tumor. Choice B, wrong. Selection bias concerns who is chosen for the study rather than the timing of diagnosis relative to a fixed death date. Choice C, wrong. Earlier diagnosis with an unchanged death date is lead time bias. Which bias explains this? A screening program is found to detect a disproportionate number of slow-growing, indolent tumors which spend a long time in a detectable but asymptomatic phase. Screen-detected cancers therefore seem to carry a much better prognosis than cancers found because of symptoms. Read the command, why screen-detected cancers look more benign. Screening preferentially catches the slow ones. This is length time bias. Slow-growing indolent tumors linger in a detectable preclinical phase far longer than aggressive ones, so a periodic screen is much more likely to catch them. The screen group becomes Ian Reich with biologically favorable tumors, making screening appear to improve prognosis when it is really just selecting less dangerous disease. The correct answer is C. Lead time bias is about diagnosing the same tumor earlier and mismeasuring survival, not about which tumors get caught, choice, or wrong. Confounding requires a third variable distorting a real association, whereas here the effect comes purely from the biology of which tumors are detectable long enough to be screened. Choice E, wrong. Preferential detection of slow-growing tumors is length time bias. What does this stratified pattern represent? A study of a new drug and risk of venous thrombosis reports an overall odds ratio of 2.0. When the data are stratified by oral contraceptive use, the odds ratio is 1.1 among non-users, but 8.0 among oral contraceptive users. Read the command, what the differing stratum estimates mean. The drug's effect is very different in the two strata. When the stratum-specific estimates differ markedly from each other, 1.1 in non-users versus 8.2 in oral contraceptive users, the exposure's effect is being modified by a third variable. This is effect modification interaction, a real biological phenomenon in which the drug's thrombotic risk depends on OC status. It should be reported stratum by stratum, not adjusted away. The correct answer is D. Confounding produces stratum estimates that are similar to each other but different from the crude value. Here, the strata differ dramatically from each other, 1.1 versus 8.1 versus 8, which is the signature of interaction, not confounding. Choice A, wrong. Random error is unsystematic noise. A clean, large, consistent split by OC use is a systematic biological pattern, not chance. Choice E, wrong. Divergent stratum estimates mean effect modification. Which effect explains the inflated observed compliance? Researchers audit hand hygiene compliance on a hospital ward. While staff know an observer is present, they clean their hands before nearly every patient contact. Covert monitoring later shows their true compliance is far lower. Read the command, why compliance rises only when watched. Being observed changes the subject's behavior. The Hawthorne effect is the tendency of people to change their behavior simply because they know they are being observed. The staff wash their hands more, not because of any intervention, but because a monitor is watching. Once observation is covert, true behavior returns. It is a threat to validity whenever an outcome is a consciously modifiable behavior. The correct answer is A. The placebo effect is in response to an inner treatment that the patient believes is active, not a reaction to being watched. No sham therapy is involved here. Choice E, wrong. Recall bias concerns inaccurate. Memory of past exposures and case. Control studies which has nothing to do with real-time observed behavior. Choice B, wrong. Behaving differently because of observation is the Hawthorne effect. Which single measure most directly prevents this expectation bias? The designers of a drug trial want to ensure that neither the patient's expectations nor the investigator's expectations can influence how the outcome is reported. Read the command, the fix for expectation bias on both sides. Hide the assignment from patients and investigators. Double. Blending keeps both the patient and the investigator unaware of the treatment assignment, so neither side's expectations can color symptom reporting or outcome assessment. It is the direct antidote to observer and subject expectation bias, a form of information bias, which no amount of sample size or randomization can remove on its own. The correct answer is E. Randomization balances confounders across groups. But once patients are assigned, it does nothing to stop patients or observers from acting on their expectations. Choice B. Wrong. Increasing the sample size shrinks random error and narrows confidence intervals, but it cannot remove a systematic expectation bias. Choice A. Wrong. Blinding both parties is what neutralizes expectation bias. What type of error has the study made? A trial concludes that a new analgesic is more effective than placebo. In reality, the drug has no true effect. The null hypothesis is actually true. Read the command, the error when a true null is rejected. Claiming an effect that isn't real is a false positive. A TYPE-IRR is a false positive, rejecting the null hypothesis when it is actually true. Here the drug truly has no effect, yet the study concluded it works, exactly that error. Its probability is alpha, the significance threshold commonly 0.05, which is the accepted risk of a false positive conclusion. The correct answer is C. A type 2 error is the opposite mistake, failing to detect an effect that genuinely exists, a false negative. But here an effect was claimed where none exists. Choice A. Wrong. Low power is the tendency to MIS. Real effects, which again describes false negatives, not this false positive conclusion. Choice B. Wrong. Rejecting a true null is a type I error. Which change most increases the study's statistical power? A pilot study fails to detect a difference that the investigators believe truly exists. Before repeating the study, they want to maximize their chance of detecting the real effect. Read the command. What raises power? Power is the ability to detect a real effect. More data helps most. Statistical power. The probability, one eye off, detecting a real effect rises most reliably by INC, raising the sample size. A larger N shrinks the standard error, making a true difference easier to distinguish from noise. Power also improves with a larger true effect, less variability, and a higher alpha, but the level investigators actually control is enrolling more subjects. The correct answer is B. Lowering alpha from 0.05 to 0.01 makes the significance threshold stricter, which actually reduces power. Choice C. Wrong. A smaller true effect size is harder to detect and therefore lowers power, the opposite of what is wanted. Choice D. Wrong. The most dependable way to raise power is to increase the sample size. What is the main problem with this conclusion? Investigators test a drug across 20 independent patient subgroups. In 19 subgroups, there is no effect, but in one, the result reaches p-0.05, and the authors headline that the drug works in that subgroup. Read the command, the flaw, in celebrating one significant subgroup out of many. Testing lots of hypotheses breeds chance findings. This is the multiple comparisons problem. With an alpha of 0.05, about 1 in every 20 independent tests will be significant by chance alone, even when nothing is real. Running 20 subgroup tests, therefore all but guarantees a spurious positive, so a single p-0.05 among many comparisons is likely a falsely positive, not a genuine subgroup effect. The correct answer is D. A p-value never proves causation. It only quantifies how compatible the data are with the null hypothesis, so that interpretation is wrong regardless of the subgroup issue. Choice B, wrong. A tag 2 error is a missed real effect, but the problem here is a spurious positive from too many tests, not a false negative choice. A, wrong. Finding one hit among 20 tests is the multiple comparisons problem. How should this result be interpreted? A randomized trial of a cardioprotective drug reports a relative risk of death of 0.85 with a 95% confidence interval of 0.05. Read the command. Interpret a relative risk whose CI includes 1. If the interval crosses the null, it is not significant. For a ratio measure like relative risk, the null value is 1. Because this 95% confidence interval 170 to 1.05 crosses 1, the data are compatible with anything from a 30% benefit to a slight harm. So the result is not statistically significant, equivalent to p2.05. The point estimate of 0.85 hints at benefit, but the interval is too wide to exclude no effect. The correct answer is A. Calling it a significant benefit ignores that the interval includes 1, so no effect cannot be ruled out. Choice B, wrong. A confidence interval crossing 1 corresponds to p above 0.05, so the claim that p is below 0.05 is contradicted by the interval itself. Choice D, wrong. Which statistical test is most appropriate? A researcher compares mean systolic blood pressure among 3 groups of patients, each receiving a different antihypertensive drug. The blood pressure values are continuous and approximately normally distributed. Read the command. The right test for 3 group means. Comparing means of more than 2 groups points to ANOVA. Analysis of variance ANOVA compares the means of 3 or more groups when the outcome is continuous and approximately normal. Because there are 3 drug groups and the variable is numeric blood pressure, ANOVA is the correct choice. A t-test can only compare 2 means, and using multiple t-tests would inflate the false positive rate. The correct answer is E. A 2-sample t-test compares only T2U group means, so it cannot handle 3 groups without repeated testing that inflates. Type by error, choice C, wrong. The chi-square test is for categorical data, comparing proportions or frequencies, not for means of a continuous variable. Choice B, wrong. 3 group means with continuous data call for ANOVA. What does this coefficient indicate? Nine, between hours of aerobic exercise per week and resting heart rate Read the command, interpret an R file -9. The sign gives direction and the magnitude gives strength. A correlation coefficient runs from -1 to +1. The magnitude here, 0.9, close to 1, indicates a strong linear association, and the negative sign means the variables move in opposite directions, more exercise, lower resting heart rate, so R 0.9 describes a strong negative linear relationship, though it says nothing about causation. The correct answer is B. Correlation never establishes CAUs. A strong R cannot prove that exercise lowers heart rate rather than sharing a common cause. Choice C, wrong. An R of C09 is very strong, not weak. A weak correlation would sit near 0. Choice are wrong. The coefficient signals a strong negative linear relationship. Approximately what percentage of individuals have a cholesterol between 60 and 240 mg/dl? In a large, normally distributed sample, serum cholesterol has a mean of 200 mg/dl and a standard deviation of 20 mg/dl. Read the command, percentage within a range. Translate the range into standard deviations from the mean. Under the empirical rule for a normal distribution, about 68% of values lie within one standard deviation of the mean, about 95% within T2U, and about 99.7% within THRE. The range 130 to 200 is 240, which is exactly the mean plus or minus TW standard deviations 2020, so roughly 95% of individuals fall inside it. The correct answer is C. About 68% corresponds to only own standard deviation, the range 180 to 220, which is narrower than the interval given choice B, wrong. About 99.7% corresponds to THRE standard deviations, the range 140 to 260, which is wider than asked choice D, wrong. A span of mean PU2, SD captures approximately 9 P2. Which of the following is a required element of valid informed consent? Before a non-emergent elective cholecystectomy, a surgeon prepares to obtain valid informed consent from a competent adult patient. Read the command, a required element of informed consent. The patient must be told what they are agreeing to. Valid informed consent requires that a patient with capacity voluntarily agrees after adequate disclosure. The nature of the procedure, its risks and benefits, and the alternatives including doing nothing. Disclosure of risks and alternatives is therefore a core element. Without it, any agreement the patient signs is not truly informed. The correct answer is D. A competent adult consents for himself, so a family member's signature is not required and cannot substitute for the patient's own informed agreement, choice, or wrong. Routine elective surgery does not need a second physician sign-off for consent to be valid, choice, C, wrong. The required element is full disclosure of risks, benefits, and alternatives. What is being assessed and who determines it? A hospitalized man with early dementia refuses a recommended amputation for a gangrenous foot. The team asks whether his refusal must be honored, so a physician evaluates whether he can understand the information, appreciate the consequences, reason through options, and communicate a consistent choice. Read the command, name what is assessed and by whom. Understanding, appreciation, reasoning, and choice define capacity. Decision. Making capacity is a clinical, decision-specific judgment that any physician can make at the bedside based on whether the patient can understand the information, appreciate the consequences, reason, and communicate a choice. It can fluctuate and is tied to the specific decision, unlike competency, which is a global legal status. The correct answer is B. Competency is a global legal determination made by a court, not the clinical judgment a physician performs here. Choice A, wrong. Capacity is assessed clinically at the bedside, not decided by a court. Court involvement is what defines competency and guardianship. Choice D, wrong. This bedside evaluation is an assessment of decision-making capacity by a physician. What is the physician's most appropriate action? A 16-year-old girl comes to the clinic alone and requests testing and treatment for a possible sexually transmitted infection. She asks that her parents not be informed. Read the command, the right action for a minor seeking STI care. Minors can consent to this confidentially. In essentially all U.S. jurisdictions, minors may consent confidentially to care for SE sexually transmitted infections, as well as contraception, pregnancy, and substance use treatment without parental notification. The physician should provide the requested testing and treatment and protect her confidentiality, respecting both the law and her willingness to seek care. The correct answer is A. Requiring parental consent contradicts the specific legal exception that lets minors consent to STI care on their own. Choice B, wrong. Notifying her parents against her wishes breaches the confidentiality she is entitled to and may deter her from care. Choice C, wrong. The correct action is to provide confidential STI testing and treatment. Who is the appropriate surrogate decision maker? An unconscious man is admitted after a car crash with no written advance directive and no designated healthcare proxy. At the bedside are his wife, his adult son, and his mother, who disagree about his care. Read the command, identify the surrogate. With no directive, follow the legal hierarchy of surrogates. When there is no advance directive and no named proxy, decisions fall to a surrogate following the standard legal hierarchy. The spouse first, then adult children, then parents, then siblings. Because his wife sits at the top of that order, she is the appropriate decision maker, and she should decide based on what HE would have wanted, substituted judgment. The correct answer is E. The adult son ranks below the spouse in the surrogate hierarchy, so he does not decide while the spouse is available. Choice A, wrong. The mother ranks below both the spouse and the adult children and would only be considered if neither existed. Choice B, wrong. The spouse is the appropriate surrogate. Which standard should guide the decision? An incapacitated man is on a ventilator after a stroke. Before his illness, he told his wife and physician clearly and repeatedly that he would never want to be kept alive on machines. His surrogate must now decide about continued life support. Read the command. Which standard applies when prior wishes are known? Decide as the patient himself would have. Because the patient previously expressed clear wishes, the surrogate must use substitute judgment, deciding as the patient himself would decide, based on his known values and statements. His documented refusal of machine-based life support should be honored. The best interest standard is a fallback used only when the patient's wishes were never known. The correct answer is C. The best interest standard applies only when the patient's preferences are you and Canaan. Here they are well documented, so it does not govern choice or wrong. Deferring to the physician's clinical judgment overrides the patient's clearly stated autonomous wishes, which is exactly what substituted judgment is meant to prevent. Choice D, wrong. Known prior wishes call for substituted judgment. What is the psychiatrist's primary obligation? During an outpatient session, a psychiatric patient makes a specific, credible threat to kill a named, identifiable coworker, describing a concrete plan. Read the command. The duty when a patient threatens an identifiable victim. Protecting the third party overrides confidentiality. Under the Tarasov duty to warn and protect, a serious, credible threat against an identifiable victim overrides patient confidentiality. The psychiatrist must take reasonable steps to protect the intended target, which may include warning the victim, notifying police, and arranging hospitalization. Safety of the third party becomes the overriding ethical and legal priority. The correct answer is D. Maintaining strict confidentiality in the face of a credible, specific threat abandons the duty to protect the third party and is not defensible. Choice or wrong. Merely documenting the threat without acting to protect the victim fails that same duty. Choice C, wrong. The obligation is to warn and protect the intended victim. What should the physician do? A competent adult Jehovah's Witness with life-threatening hemorrhage refuses a blood transfusion after clearly understanding that he will likely die without it. He is calm, consistent, and fully informed. Read the command. The right action when a competent adult refuses. Autonomy governs even against medical advice. A competent, fully informed adult has the right to refuse any treatment, including life-saving therapy, The principle of autonomy. Because he understands the consequences and is consistent, his refusal of transfusion must be respected. Transfusing over his objection would constitute battery, and beneficence cannot override a capable patient's informed choice. The correct answer is E. Transfusing against his clearly stated wishes violates his autonomy and would be battery, no matter how beneficial the intent, choice, or wrong. Seeking a court order to force treatment on a competent adult is inappropriate. Courts do not override a capable patient's informed refusal, choice B, wrong. The physician must respect the patient's refusal. Which is the best initial step? A physician must inform a patient of a newly diagnosed cancer. She wants to deliver the news in the most supportive, patient-centered way. Read the command. The best first step in breaking bad news. Find out the patient's understanding before telling. In the Spikes framework for breaking bad news, after setting up a private space, you assess the patient's perception. Ask before you tell. Finding out what the patient already understands lets you tailor the disclosure to their level, correct misconceptions, and gauge readiness. It centers the conversation on the patient rather than delivering information blindly. The correct answer is A. Bluntly stating the diagnosis and leaving abandons the patient without support or understanding. The opposite of patient-centered care, choice B, wrong. Falsely reassuring that everything will be fine is dishonest and undermines trust when the news is serious. Choice D, wrong. The best first step is to ask what the patient already knows. Which principle justifies this action? A terminally ill patient has severe, escalating cancer pain. The physician increases the opioid dose to relieve suffering. Knowing this carries a foreseeable but unintended risk of respiratory depression that could hasten death. The sole intent is symptom relief. Read the command, the principle behind giving opioids that may hasten death. Intent is relief, not death. The principle of double effect permits an action with the good intended effect, relieving intractable pain, even when it carries a foreseen but unintended harmful effect, such as respiratory depression. What matters ethically is that the intent is symptom relief, not death, and the dose is proportionate to the pain. This is standard, accepted, palliative practice. The correct answer is C. Euthanasia requires the I intent to cause death. Here the intent is to relieve pain, not to kill, so it does not apply. Choice B, wrong. Physician-assisted suicide means providing a patient the means to end their own life, which is not what titrating analgesia for comfort is. Choice A, wrong. Relieving pain while accepting a foreseen, unintended risk is the principle of double effect. Which defense mechanism is he using? A man is humiliated by his supervisor at work, but says nothing. He comes home and, over a trivial matter, shouts angrily at his young children. Read the command, name the defense mechanism. Anger is redirected from a threatening target to a safer one. Displacement is the transfer of an emotion from its original th-treating target onto a safer, less threatening substitute. Unable to express anger toward his boss, the man redirects it onto his children. The feeling is unchanged, only its target is shifted, the hallmark of displacement. The correct answer is B. Projection is attributing one's OWN unacceptable feelings to someone else. For example, insisting the boss hates him, not redirecting the anger onto a third-party choice, a wrong. Sublimation channels an unacceptable impulse into a socially constructive outlet, such as exercise, and is a mature defense. Unlike lashing out at his children, choice C, wrong. Shifting anger onto a safer target is displacement. Which sleep stage is this, and what is its key feature? A sleep study captures a stage in which the EEG resembles wakefulness, low voltage, high frequency, the eyes move rapidly, and skeletal muscles are atonic. Most vivid dreaming occurs during this stage. Read the command. Identify the stage and its feature. Wake, like EEG plus rapid eye movements plus atonia points to REM. REM sleep shows an EEG that paradoxically resembles wakefulness's low voltage, high frequency, beta-like rapid eye movements, and profound skeletal muscle atonia that prevents acting out dreams. It is when most vivid dreaming occurs, is driven by high acetylcholine, and lengthens across the night toward morning. The correct answer is D. And 3 is deep slow, wave sleep dominated by high amplitude delta waves, the opposite of REM's fast, low voltage pattern, and it is the stage of night terrors and sleepwalking, not vivid dreaming choices. C and E wrong. N2 is marked by sleep, spindles, and K complexes, not rapid eye movements and atonia. Choice B, wrong. This wake-like atonic dreaming stage is REM sleep. That's the block. 40 questions of the material that decides the easy points on test day. Let's lock the highest yield traps in 60 seconds. Sensitivity and specificity belong to the test. Predictive values belong to the population. Likelihood ratios travel anywhere because they use only sensitivity and specificity. Match the measure to the design. Odds ratio for case control. Relative risk for cohort. Ratios divide. Attributable risk subtracts. Screening fakes benefit two ways: starting the clock early or catching slow tumors. Confounding you adjust away. Effect modification you report. Type 1 cries wolf. Type 2 misses the wolf. If the confidence interval crosses the null value, it is not significant. When the patient's wishes are known, decide as they would. A competent, informed adult can refuse anything, even life-saving care. Train process, not memorization. StepLogic, learn how to think, not memorize. Next weekend, we drill microbiology.